Hello everyone, I am Naz, and my friends are Şanser and Orkun. Today we will be presenting our study titled Managing Chemotherapy-Induced Neutropenia using Exogenous Granulocyte Colony Stimulating Factor. This project started as our bachelor's graduation project under the supervision of Gönenç Yücel more than a year ago, and here we go. Our introduction will serve as a brief background on the dynamic problem and our model boundary. Chemotherapy is the drug-incorporated approach used for cancer treatment. Chemotherapy's effect of massive cell deaths is realized in the cells that are under rapid growth, such as cancerous cells. However, along with cancerous cells, other rapidly growing cells are also affected by chemotherapy, such as cells that produce hair, nails, and also stem cells in the bone marrow that produce white and red blood cells. The most abundant type of white blood cell in the bloodstream are neutrophils. Neutrophils are the leading unit in evading and fighting bacterial or fungal infections. Being the first line of defenders, without neutrophils, human body is vulnerable against even simpler infections. Low concentration of neutrophils resulted by chemotherapy treatment is called chemotherapy-induced neutropenia. Chemotherapy-induced neutropenia is one of the most common adverse effects of chemotherapy and frequently threatens the continuity of the treatment. If neutrophils fall below a certain limit, chemotherapy is delayed, and neutropenic patients have higher risk of infections that leads to hospitalization or even death. 70% of untreated patients with severe neutropenia die within the first day, indicating that neutrophils are crucial to survive. GCSF is the internal glycoprotein that regulates neutrophil production through chemical pathways. Based on circulating neutrophil numbers in the blood, GCSF controls the neutrophil production by reducing the maturation and production time of neutrophils and increasing stem cell and neutrophil proliferation, essentially closing a balancing loop. Under the influence of external chemotherapy agents that creates a neutrophil shortage through stem cell deaths, internal GCSF does not suffice. In order to stimulate neutrophil production and compensate for the negative effects of chemotherapy, exogenous GCSF, its recombinant form filgrastim, is co-administered with chemotherapy. If their simultaneous usages are fitted to an effective regime, chemotherapy-induced neutropenia can be prevented and chemotherapy can be conducted with full efficiency. The main purpose is to keep the absolute neutrophil count above a critical limit or minimize the time spent under the critical level in order to avoid lethal consequences. Timing and dosage of GCSF, as we call it protocol parameters, are crucial in coming up with an effective treatment. There is a dynamic trade-off regarding the GCSF use. Insufficient GCSF administration leads to insufficient stimulation, while excessive GCSF causes stem cell pool to wear off and damages in the long run. Current treatment protocols follow trial and error method, and decisions are made based on momentary neutrophil level counts. Not addressing the dynamic nature of the problem, this approach often fails. So why we need a dynamic perspective? Long material delays in neutrophil production and numerous feedback loops within the system results in a complex structure. On top of that, external agents such as exogenous GCSF and chemotherapy paired with variability in patient responses due to patient state, physiological differences, and pharmacokinetic pharmacodynamic responses introduce new interactions and dimensions to the problem. All these makes it crucial to understand the causal relations and intertwined processes of this complex system in order to manage this dynamic problem. In this regard, we aim to build a causal descriptive model that will help us analyze the underlying structure. Stem cells continuously produce neutrophils. GCSF acts as the controlling factor to neutrophils by stimulating stem cell production and rate of flow from stem cell to neutrophil compartments. In the meantime, internal production of GCSF is downregulated by high neutrophil counts in blood, completing the negative feedback loop. Chemotherapy agents kill stem cells and reduce the rate of flow between stem cells and neutrophil, which eventually causes chemotherapy-induced neutropenia. To compensate for the negative effects of chemotherapy, exogenous GCSF can be administered. Since it has the same effects as internally produced G-CSF, it will boost neutrophil levels.
A more detailed look is provided in a causal loop diagram. Stem cell density negatively affects amplification and proliferation rates, which closes two internal balancing loops. Neutrophils are produced from these stem cells after undergoing several phases, which include lineage commitment, mitosis, and maturation. Mature neutrophils in the bone marrow reservoir are mobilized into circulation before completing their lifespan. G-CSF acts as the centerpiece of this total, regulating each of these processes. On each level, G-CSF effects are close to balancing loops, with the negative link from neutrophils to G-CSF. Chemotherapy agents cause direct cell deaths in 3 of these stages, which we will elaborate further in the stock flow diagram. G-CSF administration is a supporting external touch to the system in order to stimulate the balancing loops that would keep the neutrophil levels above a neutropenic threshold. Now the stock flow structure. 2 stocks on the left represent the resting stem cells and the mitotic stem cell pool undergoing proliferation and amplification. Stem cells committed to the neutrophil lineage are amplified in number, then move into phase of maturation. After this phase, mature neutrophils join the bone marrow neutrophil reservoir. There is a huge amount of stored neutrophils in bone marrow reservoir waiting to be released in case of any emergency, such as inflammation. Last stock represents the number of neutrophils in circulation, and absolute neutrophil count, ANC, is calculated using this stock. Note that the main line is analogous to a high-order supply chain with many delays, meaning that if a change occurs in a stem cell level, it would take several days to observe its effect on neutrophil levels, and G-CSF controls the process with its effect formulations. Pharmacokinetics of G-CSF is modeled with a simplified quantitative systems pharmacology method. First, drug is liberated to the site of administration and joins the injected G-CSF stock. Then, injected G-CSF is absorbed to the tissues and joins the circulating G-CSF stock. Circulating G-CSF stock represents the effective G-CSF in circulation, and physiological effects of G-CSF roots from here. Ultimately, drug is cleared from the body with a renal elimination outflow. A further emphasis on the G-CSF effect is shown here on the main line of the stock flow diagram with G-CSF pharmacodynamics. Circulating G-CSF level affects the stem cell and neutrophil flows with specific graphical effect functions, calibrated using the information found in the literature. Neutrophil apoptosis, which is the programmed cell death, negatively affects the G-CSF level. Pharmacokinetics of chemotherapy is adapted from the 4-compartmental model of Perez-Ruijo. Chemo in circulation is the effective cytotoxin level in circulation. Other compartments, C2, C3, and C4, represents the other tissues that are away from the circulation. Agents exchange between tissues before elimination, which slows down the clearance of the drug. This is the neutrophil production chain we have shown before, along with the influences of G-CSF and chemotherapy. Cell deaths caused by chemotherapy in circulation are modeled as outflows from 3 compartments in neutrophil production diagram. These are resting stem cells, neutrophil-committed stem cells, and bone marrow neutrophil reservoir. Also, neutrophil amplification is significantly reduced. These effects are calibrated to imitate the behavior of CHOP14 chemo regimen. Since chemotherapeutic damage is mainly directed at the early stages of this chain, the effect of chemotherapy, just like G-CSF, can only be observed on neutrophil level after several material delays. Model parameters are taken from various studies in the literature. These include both clinical and modeling studies. Initial values of some stocks, as well as several of fractions, are derived using traffic balance equations under homeostatic or equilibrium conditions. After building our model under homeostatic conditions, we use some of the data in literature to tune our parameters and some others to validate our model. To do that, we compared the behavior of our model with the data from literature under same conditions and inputs. In these two, we see the absorption and elimination behavior of exogenous G-CSF for repeated administrations. Our model results on the left and the data from Scholz et al. On the right. We see they follow a similar pattern. To validate the effectiveness of G-CSF on neutrophils, we compared A and C graphics for different single doses of exogenous G-CSF. On the left side, you can see the results from our model, and on the right, data taken from Krzyzanski et al. Graphs match, as you can see, in terms of maximum points, time passed until maximum, and final results after 70 hours. On the right, you can see the ANC levels for continuous G-CSF administrations in the absence of chemotherapy from literature. On the left is the responses of our model for the same G-CSF regime. Graphs reach their peaks around the same time and continue stable oscillations with a slowly increasing trend. Simulation experiments are conducted for one type of chemotherapy, that is CHOP14, which is administered biweekly. Although in real life, continuity of chemotherapy depends on the current neutrophil level, timing of chemotherapy administration is assumed to be same for all experiments. Time horizon for the experiment is 6 cycles of chemotherapy, but only a portion is presented in graphs. Analysis for the neutrophil dynamics will be elaborated, starting with the ANC response for standard protocol. Then, focus will be some particular cases from the sensitivity runs that allows us to classify 3 governing dynamics. And finally, patient-specific responses will be analyzed. Graph shows the ANC response during concurrent CHOP14 regime and is commonly recommended G-CSF protocol, as we call it the standard treatment. Standard treatments start from day 4 post-chemotherapy to day 13 for a total of 10 injections, 480 micrograms each. To make the representations clear, a small legend is added under the graphs. Each bar represents a day, where red bars indicate chemotherapy administration, and green bars indicate days of G-CSF administration. First of the 10 doses of G-CSF is given 4 days after chemotherapy. As we can see, this causes an initial peak in ANC due to immediate mobilization of neutrophils from the bone marrow reservoir to circulation. However, the peak is short-lived, and ANC continues decreasing when the actual effect of chemotherapy hits at the 7th day. G-CSF stimulation of stem cells reaches ANC before it falls before the neutropenic limits, and the patient is saved. Similar behaviors are observed for the next cycles, but with different magnitudes. Ultimately, standard protocol performs well in preventing neutropenia.
To quantify the severity of neutropenia, 2 measures are used: number of neutropenic days and minimum level that neutrophil counts drop, namely nadir. A G-CSF protocol is defined by 2 parameters: start time and number of injections. The analysis is conducted to measure the sensitivity of ANC to changes in these 2 protocol parameters. After conducting experiments with various protocols, we have deduced 3 governing structural dynamics. Whether a protocol succeeds or fails depends on the trade-off between these dynamics. Among all of the experiments, we will present 3 sample runs, each failing due to one of the dynamics. Here, a protocol with an additional shot at the end of the standard protocol is simulated. In this case, we can see that the initial peaks are more smoothed than before, and after each peak, patient experiences neutropenia, a total of 6 days. This indicates that the patient is not given enough recovery time between the end and start of G-CSF for consecutive cycles, which prevents the bone marrow reservoir to fully recover itself before the next cycle. For the second case, patient is given 2 less G-CSF shots. 8 shots in total fail to stimulate neutrophil production enough to deal with the adverse effects of chemotherapy. Similar to the first case, initial peaks are smoothed compared to the standard protocol, not because there is not enough time to recover, but less number of injections fail to stimulate the upstream stocks to keep ANC above neutropenic threshold. Parallel to this inference, clinical research conducted by Smith et al. Suggests that more than 7 injections of G-CSF or recombinant form filgrastim decreases the risk of febrile neutropenia by 65%. For the last run, G-CSF injection starts 2 days earlier than the standard protocol and continues for total 10 injections. The reservoir is depleted way earlier than the actual effect of chemotherapy manifests. Thus, patient falls below neutropenic limit in each cycle after the true colors of chemotherapy is realized at the ANC level. Timing of the first dose should be in such a way that it should utilize the safety stock to prevent the initial fall and stimulate the production to fill the neutrophils when in dire need, not too early or not too late. In the presented model, recommended G-CSF protocol works well for the standard patient. However, one protocol working for all patients is rarely the case in real life. Therefore, to measure the sensitivity of protocols against the variability in physiological characteristics, several patient profiles were defined using 3 model parameters in their meaningful range. Chemosensitivity is modeled by changing the average time that chemotherapy agents spend in the system. GCSF absorption is related to how fast the GCSF is absorbed and become effective in circulation. Finally, material delay fraction, or MDF, is a measure of speed of all internal flows. Here, 3 different GCSF protocols are tested on chemosensitive patient profile. As can be seen from the graph in the middle, standard protocol yields around 6 days of neutropenia. Considering that insufficient stimulation of neutrophil production, the second dynamic, may be the problem, to come up with an improved protocol, a protocol with more number of injections is tried by adding 2 extra shots at the beginning, the graph on the left. However, the protocol performs worse than the standard protocol with 12 neutropenic days. Since cytotoxic presence in circulation is prolonged for this profile, maximum effect of chemotherapy is also delayed. Therefore, instead of increasing number of injections, to increase the recovery time between the consecutive GCSF cycles and save the safety stock for the time where neutrophils are most needed, we tried a new protocol by skipping the first injection of GCSF. The protocol yields less number of neutropenic days, suggesting that dynamic 1 and 3 seems more influential for this profile. To examine the impact of same treatment protocols on different patients, low GCSF absorption and high MDF patients are subjected to 3 different GCSF protocols. As shown in figure on the left, standard protocol fails to keep ANC levels of both profiles above a critical level. Remember that for high MDF profile, we have faster flow of materials. Therefore, chemotherapeutic damage on circulating neutrophil levels is observed earlier, and elimination of GCSF occurs much faster. The protocol that starts 2 days after chemotherapy with 12 number of injections perform better since the timing of the first dose is more suitable and stimulation of neutrophil production more effective with this protocol. However, it's not the case for low GCSF absorption profile. For this profile, GCSF spends more time in the system, suggesting that the last injection is still effective when the next chemotherapy kicks in for the standard protocol. Therefore, skipping the last injection provides longer time for the bone marrow to recover and prevents neutropenia. It is important to notice that one protocol that works for one patient profile leads heavy consequences for the other. Moreover, governing dynamics for each profile is different than the other. For high MDF profile, dynamic 3 and 2 seems influential, whereas dynamic 1 is effective for low GCSF absorption profile. Consequently, optimal treatment protocols also differ for such cases, suggesting that personalization of treatment protocols is essential under current parameterization. All in all, the system involves many trade-offs, suggesting that it is hard to come up with a one-fits-for-all GCSF protocol. From different simulation experiments, patient characteristics are found to be significant on the outcome. Inclusion of multiple delays, nonlinear relations, and various feedbacks makes the problem a difficult dynamic management task and makes it harder to solve it with a static perspective. The model we built is capable of capturing these dynamics, and it can be used both as an assistant and a learning tool for practitioners. Thank you all for listening. You can check out our paper from web portal for further details. We hope you'll have a wonderful time during the conference.